Quite often for us, peripheral neuropathy and diabetic peripheral neuropathy in general practice has become synonymous. And when we think of peripheral neuropathy per se, the number of causes, the etiological evaluation that can be done is extensive. Peripheral neuropathy, as we know, is basically damage to the peripheral nerves, and it affects approximately 1% of adults worldwide. So this is a staggering number. And there are more than 200 causes for peripheral neuropathy. One thing we should never ever forget, and in India, infectious etiologies like leprosy and HIV are common causes, relatively common causes of neuropathy that one must never forget during the evaluation workup. Pathology guides treatment and prognosis in immune mediated neuropathies. Temporal evolution of symptoms and the timeline is of paramount importance in appropriately diagnosing and treating.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked video so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
So today's topic, what we will be dealing with is peripheral neuropathies, rare causes and workup beyond diabetes. Quite often for us, peripheral neuropathy and diabetic peripheral neuropathy in general practice has become synonymous. And when we think of peripheral neuropathy per se, the number of causes, the etiological evaluation that can be done is extensive. So hopefully by the end of this talk, I want to try to convey a kind of an algorithm which we can follow when we see these patients with peripheral neuropathy in our day-to-day practice. So beginning with the epidemiology. Now, peripheral neuropathy, as we know, is basically damage to the peripheral nerves, and it affects approximately 1% of adults worldwide. So this is a staggering number. And there are more than 200 causes for peripheral neuropathy. And to define what type of cause it really depends on the symptom onset, progression, etc. Diabetes, yes, it is one of the most common causes of neuropathy, affecting approximately 206 million people worldwide. Now, the wide range of peripheral nerve diseases with similar clinical presentations pose a diagnostic challenge. And applying a clinical framework for patients with peripheral nerve disorders can help us in differentiating clinical features and ultimately leading to a precise diagnosis. And one thing we should never ever forget, and in India, infectious etiologies like leprosy and HIV are common causes, relatively common causes of neuropathy that one must never forget during the evaluation workup. Now, we start from the basics. So we know that the nerve fibers are divided into the large fibers, the small fibers, motor, sensory, autonomic, and they are myelinated and unmyelinated. And it is this, at this juncture, knowing this knowledge will tell us what are the various pathophysiological mechanisms which cause damage in peripheral neuropathy. So what we have now, if we bring in the sensory nerves, we know that the cell bodies are in the dorsal root ganglia, and they can be large or small, myelinated and small unmyelinated axons. And in the motor nerves, the cell bodies of the anterior Hall cells are within the spinal cord, and they have large myelinated axons. And when it is autonomic axons, they are of course unmyelinated. So we come back to this when we have the pattern recognition of myelinated demyelination versus an axonal involvement. And what we need to know that the signs and symptoms of if it depends on whether it's predominantly sensory, purely motor, or sensory motor. I will circle back to the symptoms later. Now, what we need to know in the peripheral nerve anatomy, which is common across the board, is that we have the epineurium, the perineurium, and the endoneurium. And the Schwann cells myelinate the large and small axons, and they envelop the small unmyelinated fibers. And neuropathies occur when the neurons die, when the axon degenerates, neuronal excitability is altered, or there is Schwann cell dysfunction leading to failure to maintain conduction velocity or provide axonal support through growth factors. So any of these mechanisms involved can cause damage to the peripheral nerve. And this is a very beautiful diagram which shows how the damage decreases conduction velocity, interrupts signal transmission in demyelination, and then what happens in an axonal variant. So now, what are the basic mechanisms by which damage happens to the peripheral nerve? They can be demyelination, axonal degeneration, Wallerian degeneration, compression, infarction, or infiltration. Now, these are the 6 base mechanisms which can cause peripheral nerve damage. Now, we do know that the most common pattern of peripheral neuropathy is the length-dependent peripheral neuropathy. That is the most common type of peripheral neuropathy that we encounter in our day-to-day practice. And here it is predominant sensory motor length-dependent peripheral neuropathy. That is the most common clinical phenotype. And why this sensory predominance is there is not completely understood, but one of the mechanisms is proposed to be due to the presence of fenestrated capillaries in the dorsal root ganglia, which reduce the blood neuron barrier and increase the susceptibility to systemic factors such as hyperglycemia or exposure to neurotoxic medications. So essentially, we know that axonopathy is dying back. The mechanism proposed that axonoplasmic flow is the most vulnerable, will be the distal most or the longest nerve fibers. And sensory predominance is because of this particular factor. And the concept of the blood nerve barrier is something very, very important, because when there is a compromise in the blood nerve barrier, it is then that the systemic, either it is a toxin or it's an immune mediated complex, can attack the peripheral nerve. So that is one important concept that we should know of the blood nerve barrier. Now, coming to the individual mechanisms. So we begin with demyelination. So basically, demyelination refers to the degeneration of the myelin sheath, which will in the initial stages spare the axon. But we do need to remember, in severe long-standing demyelinating neuropathy, there is secondary axonal damage as well. And the clinical presentation can be varied. They can be mononeuropathy, sensory mononeuropathy. So they may not be, they are usually not length dependent, but they can be length dependent as well. And one very unique, or rather more unique thing about this is that it is characterized by diffuse areflexia, and they are often inflammatory, and about 20% of symmetrical peripheral neuropathies do result from damage to the myelin, while 80% are because of axonal damage. Now, Wallerian degeneration occurs after a nerve axon degenerates due to a lesion of physical compression. The portion distal to the axon will progressively, passively waste away. And this is likely due to lack of nutrients from the cell body. And this reaction results in focal mononeuropathy, which can be secondary to trauma or secondary to infarction of the nerve. And then we come to axonal degeneration, the most common form, the most common mechanism to cause peripheral neuropathy, also called the dying back phenomena. Usually it causes asymmetric polyneuropathy. It can cause weakness, most commonly dorsiflexors, and then there can be accompanying trophic changes as well. And this proposed mechanism again here is impaired delivery of the local axonal survival factors, and this will result in increased level of calcium intraaxonally, leading to calcium dependent cytoskeleton breakdown. So this calcium dependent cytoskeleton breakdown, and again there are thousands of mechanisms proposed, but this is one of the key mechanisms noted in axonal neuropathy. So this is again an illustration of the same, and we see the temporal progression from early to late to, if there is a stage of recovery, how there is a dying back destruction within the peripheral nerve axon. And now this was what is the pathophysiology. Now, if we want to divide or classify peripheral neuropathy, there are several types of classification. Now, peripheral neuropathy can either be acute or chronic, depending on the temporal course. Depending on the number of nerves involved, it can be mononeuropathy, polyneuropathy, or mononeuritis multiplex, or it can be a radiculopathy, which wherein the disease is affecting the nerve roots, like what we see in AIDP. And it can affect sensory, motor, or autonomic pathways, or more commonly, as what we see in our clinical practice, a mixture of all three. Now, when we see a monomelic distribution of sensory motor symptoms, monomelic would represent a single limb. What it suggests is there's a focal neuropathic process, and this can include compressive mononeuropathies, isolated radiculopathies, or very rarely autoimmune conditions that affect the brachial and lumbosacral plexus, like multifocal motor neuropathy, multifocal CIDP. And a patchy distribution, that is a non-length dependent distribution, is asymmetric. It can involve proximal regions along with face and trunks, and this can suggest an autoimmune neuropathy as well, where random segments of the nerve root and peripheral nerve are picked off one by one. So this is the classical length-dependent pattern which we can see in diabetes, nutritional deficiencies, toxin-induced metabolic. And it is, again, what we say is the stocking and glove type of sensory loss. So what we usually say is that it starts with the feet, and as it progresses, by the time it reaches the mid-thigh, then the finger sensation starts getting impaired. By the time it ascends further and reaches the mid-forearm, the anterior abdominal fibers, anterior abdominal sensations are affected. So basically, it really depends on the length of the nerves involved. And this is what we classically see in diabetic peripheral neuropathy. This is another example of the pattern seen in hereditary sensing neuropathy with extensive distal sensory loss. And we can see that only an area of the body is spared. This is how it is in Tangier's disease. And then when there is, so that was the length dependent pattern, the most commonly encountered one. And then we come to the non-length dependent pattern, which is symmetrical or asymmetric proximal and distal weakness with sensory loss or positive sensations. And this is what you can see in MADSAM variant of CIDP, or what you see in amyotrophy. So we had the monomelic variant, then we had the non-length dependent pattern, and then the most common pattern, which is of course the length dependent pattern. And mononeuritis multiplex, or multiple mononeuropathies, this is where we get contiguous sequential non-contiguous nerve involvement, and this is a hallmark usually of vasculitic neuropathy. But we should remember that it can also be seen in leprosy, and it can also be a manifestation of diabetes neuropathy itself. But again, it's a red flag sign, and when encountered, even in the context of poorly controlled diabetes, workup for other causes have to be done. Now, so we understood the mechanisms, we understood the patterns of involvement, and now we are going to jump into the clinical symptoms. Now, I have divided the clinical symptoms into sensory symptoms, motor symptoms, and autonomic symptoms. But again, to reiterate, it is quite rare for us to get purely motor, purely sensory. There are a few causes which I will tell, but in general, usually it is a mixed type of neuropathy that we encounter. So when we have sensory polyneuropathy, these are the, again, it will depend whether it's the large myelinated fibers or the small unmyelinated fibers that are involved. So we can have paresthesias, numbness, burning, loss of vibration sense, difficulty using objects due to the proprioceptive loss, subacute ataxia, and a stocking and pattern of sensory loss. So we can divide them into loss of function and disordered function, and again into sensory large fiber and sensory small fiber. So the loss of function will be loss of vibration sense, loss of proprioception, hypo or areflexia, and sensory ataxia, while the positive signs would be paresthesias. While in the small fiber, it would be reduced pain and temperature, while patients have severe dysesthesias and allodynia. And in fact, small fiber neuropathies are some of the most painful type of neuropathies that there are. When it comes to motor neuropathy, there's progressive weakness, clumsiness, there is falling. If there is ascending respiratory weakness in acute conditions, there can be falling vital capacity, classically wasting. In axonopathies, there can be foot or wrist drop, and reflexes can be absent or reduced. Again, if we divide it into loss of function, there can be wasting, hypotonia, weakness, hyporeflexia. There can be skeletal deformities, especially in inherited neuropathies, and disturbed functions can lead to fasciculations and cramps. What a point to be noted here is that wasting is commonly seen in axonal type of neuropathies, and in the late stages of demyelination, of course. But classically, we get wasting in an axonal variant. When it comes to autonomic neuropathy, patients can present with postural hypotension, urinary retention, erectile dysfunction, diarrhea, alternating diarrhea with constipation, diminished sweating. They can have cold or heat intolerance, impaired pupillary reflex, which is manifest as delayed dark adaptation. They can have cardiac arrhythmias. And it is classically, when there is a excess of autonomic symptoms, we do think of diabetes, amyloidosis, and GB. These are three things we should always remember when a patient has gross autonomic symptoms. Amyloidosis should be something that we should never ever forget. Again, this can be divided into loss of functions or disturbed functions. Now, coming to the causes. So, as I told you, the causes are 200, and this list will keep on expanding. But the major ones that we do need to remember, and these are the ones that will later on help us in terms of evaluation also. And we begin with the most common causes, which are the systemic causes, which are the endocrine causes, which is diabetes, connective tissue disorders, nutritional deficiencies, and do remember B6 overdose as well. Inflammatory conditions like AIDP, CIDP, and I will be talking a little bit more on detail in that. Metabolic conditions like uremia, infective conditions, again, never ever to forget. Leprosy, HIV, diphtheria that can mimic GB. Again, however, is descending in nature. Malignancy, which is paraneoplastic or by direct infiltration, and critical care neuropathy. Toxins, again, a whole lot of toxins can cause it. I'll discuss briefly about them later. Hereditary neuropathy, the most commonly what we are familiar with, the Charcot-Marie tooth. Environmental, vibration-induced occupational exposure, and idiopathic. And this is something that is quite a fact of the matter, that several studies, several meta-analysis, several epidemiological surveys have found that despite extensive evaluation, up to 12 to 49% of neuropathy can often go and become idiopathic, like wherein we are not able to find the cause. And we will conclude on that note as to what to do in those scenarios. Drugs, again, a whole lot of drugs can cause peripheral neuropathy. The ones that we are very familiar with, of course, are the onco drugs that are used. But we do need to remember some of the common drugs that we probably prescribe, which include fluoroquinolone, metronidazole, phenytoin. These are drugs that we commonly use, which also have evidence of causing peripheral neuropathy, and something we should remember. Toxins, again, in the context of occupational exposure, one, in the context of patients who are farmers who are dealing with organopesticides, and that is one history that we should always remember to take. One more thing we do need to remember is history of Ayurvedic medication consumption, and not the Ayurvedic medication from the prescribed and the licensed people, the over-the-counter dealers, which may contain heavy metals. So that is one history we should always include when we are assessing such patients. So now that we have understood, we have come across the mechanism, the patterns, and the overview of the causes, let us go break down some few common neuropathies. So beginning with what was included in the title, in fact, diabetic neuropathy. So now diabetic peripheral neuropathy is the most common cause of neuropathy, definitely. And among diabetic peripheral neuropathy, the most common clinical phenotype is the predominant sensory motor length dependent neuropathy. And again, it goes back to the same thing, that these are metabolically sensitive length dependent nerves, and they, because of their vulnerability, they multiple mechanisms are proposed, which include damage to the vasa nervosum also, but it is predominantly the metabolic insult which causes this type of neuropathy. But what we do need to remember, that in diabetes also there can be mononeuritis multiplex, there can be mononeuropathies, they're more predisposed to our compression carpal tunnel syndromes, etc. And we also need to remember of diabetic amyotrophy, which is a form of localized plexopathy, which in fact is supposed to be, there are a lot of there's a data coming out that's saying that is immune mediated, and in fact in those cases steroids may actually be indicated. So the pattern which I have illustrated in this diagram is vast, but whenever you have diabetic peripheral neuropathy not in the common phenotype, you do need to think of other causes, and I'll tell you what. So this is an overview of diabetic neuropathy in general. We do know that it is length dependent. We do know that on the conductions, there will be sensory axonopathy. Snap amplitude will be reduced. It can be generalized, multifocal. Treatment, I will not elaborate too much on, but essentially, the first line medications as per FDA are SNRIs, including duloxetine. Gabapentinoids is the second drug. More than the positive paresthesias, they have loss of sensation, so they have to be educated regarding food hygiene, food care, because many of them end up with diabetic ulcers, and that can be a downhill path. Now, characteristics that are atypical for diabetic peripheral neuropathy, that's something that we have to keep in mind. Asymmetry, initial presentation with weakness more than sensory loss, and rapidly progressive disease course. Now, again, asymmetry can be there, but you have to think of underlying, rule out other etiologies like vasculitis. Always, whatever patients of diabetic peripheral neuropathy you would have seen in your clinical practice usually have sensory predominant symptoms. If a patient comes with predominantly motor symptoms, do think of other causes. And rapidly progressive disease course. One thing we do need to remember is that patients with diabetes are at a much higher risk of developing CIDP than the general population. And not quite often, but the inflammatory component, that is the CIDP component, can be ignored, and we can think that maybe it's just diabetes that is going on and causing this peripheral neuropathy, and we may lose precious time where an intervention between initiation of immunomodulation might have prevented further irreversible nerve damage. So always, this is a very, very important point, that at the initial presentation, if the weakness is more than the sensory loss in diabetic patients, do consider the possibility of other etiologies. And a small note on treatment induced neuropathy of diabetes, and this is a variant of length dependent peripheral neuropathy. It occurs after rapid correction of hyperglycemia. They say glyco HB of 2% over 3 months, and it's very severe, it is painful, it is small fiber. So we know small fiber is autonomic, so they have autonomic symptoms as well. So this was about diabetic peripheral neuropathy. Now the topic is rarer forms of neuropathy, so I'm not going to go much into it. But in diabetic, what I would like to reiterate is that, see, in type 2 diabetes, in type 1 diabetic patients, it is only the glycemic control that will prevent progression of this peripheral neuropathy. But in type 2 diabetics, it is not just glycemic control, it's also the entire metabolic profile, dyslipidemia, lifestyle factors, smoking, everything which has a impact on the progression of symptoms. So that is something that we should educate all our patients, because we can reduce the tempo of progression, if not halt it completely. Now, coming to the next most common and most important type of peripheral neuropathy, which is the immune-mediated neuropathies. And these are a heterogeneous group of disorders. They have wide-ranging clinical presentation, and the immunological process may either be at the level of the peripheral nerves or the supporting blood vessels. And the resulting syndromes are influenced by the target and specificity of the immunological attack. Now, among these inflammatory, immune-mediated inflammatory neuropathies, the acute aspect I will not deal with today, because that is a topic in itself, and that is, of course, Guillain-Barré syndrome. But the chronic form of it, which is a chronic inflammatory polyneuropathy, is what we will be dealing with. And on that note, in this slide, there is just a mention of the rarer immune-mediated inflammatory neuropathies as well, because we have the recently discovered antibodies, which are the nodopathies, and which can mimic, some of them can mimic GB, some of them can mimic CIDP, of which we should be aware of. Then we have the ones associated with monoclonal gammopathies. So these all come under the bucket of the spectrum of immune-mediated inflammatory neuropathies. Now, coming to CIDP per se. Now, CIDP is an acquired peripheral neuropathy. There is both B and T cell involvement. It is one of the most common peripheral autoimmune demyelinating neuropathies. And what happens is, so here we have an illustration of what I was telling you before. So here we have the blood nerve barrier, and here we have the systemic immune compartment, and we have some trigger which is triggering the immune system, and we can see the antigen presenting cell here, which is going and activating the CD4 cells, and there's release of cytokines and this release of adhesion factors. This will increase the permeability of the blood nerve barrier, and all these activated cells then come into and attack the nerve. And then we can see here there's simplification of the node of Renvia. And then here again it depends on what is the target, whether the target will predominantly be the axon or predominantly be the myelin sheath. And here we have an electron microscopic view of what is happening here with macrophage mediated demyelination, and we can see that there is very thinly remyelinated axons. So that is why there is the relapses and remission, where there is demyelination, attempted remyelination, attempted remyelination, and that is why we get thickened nerves in this patient. So clinical features, again, it is progressive, it is usually symmetrical, can be asymmetrical, relapsing or progressive. The cutoff here is 2 months, because anything less than 2 months, if it's 4 weeks, it's AIDP, 4 to 8 weeks, it is SIDP, and then beyond that, it is CIDP. The sensory symptoms are common. Neuropathic pain is not that common, and patients usually have unsteadiness of gait because it's a large myelinated fibers are usually involved. They usually have a polyradicular neuropathy pattern of weakness because of involvement of the motor roots, and they have large fiber sensory loss, and generalized, again, to reiterate, the demyelinating variant especially has generalized hyporeflexia. In fact, the muscles which are not weak, the limbs which are not weak also will have areflexia or hyporeflexia. And this is a clinical clue for you to say that the underlying mechanism could be likely demyelination. And this is a diagram which beautifully tells us the various types of CIDP. So we have a typical CIDP, we have distal predominant CIDP, we have multifocal CIDP or the MADSAM variant, we have pure potentially motor or potentially sensory CIDP, and each of them, so for in each of them we have to do the usual workup. We have to make sure that there is no alternative diagnosis, we have to go ahead for the nerve conductions, and we have to go ahead for the confirmatory test as well. And as per the EFNS criteria, each of these have their specific electrophysiological requisites to say that they fall in. But commonly we don't see CIDP patients, very, very classically fitting this criteria. But yes, for each variant, there are set of criteria, and we have to try to apply them. And what are the ancillary supportive investigations? It's elevated CSF protein, MRI showing gadolinium enhancing nerve roots, ultrasound showing nerve enlargement. Again, this is because of the demyelination. And then there is objective clinical improvement following immunomodulated treatment. And nerve biopsy, of course, not always indicated. If your patient is fitting the clinical electrophysiological criteria and you have reasonably ruled out the other cases, nerve biopsy is not indicated. And I will tell you where, in which clinical scenarios exactly nerve biopsy is indicated. And this is how we are seeing an ultrasound nerve, and it is ultrasound is a beautiful non-invasive test when you are suspecting that your patient might have CIDP, because without any a simple, you can see the cross-sectional area, see the echogenicity, comment on whether there is probable inflammation going on there. MRI, of course, a little more expensive, but then it again, the thickening of the nerve roots can be a very important, again, non-invasive supportive evidence to make your clinical diagnosis. And of course, I'm not going to details of CIDP management because that's a long drawn process, but we do know the first line is always steroids. And very rarely, when patients do not respond to steroids, they may require rescue plasmapheresis or rescue IVIG. And then we switch them over to steroid sparing agents, which can be mycophenolate, azathioprine, depending on the other comorbidities. Not in India, but abroad, IVIG itself is given in terms of maintenance treatment. And now the most recent development to take place was that subcutaneous immunoglobulin was also approved, and that is also being given regularly in, of course, in other countries. And a lot of new immunosuppressants have come in the line. But the importance here is that to make an early diagnosis. So the earlier we initiate these immunomodulatory treatments, the better the chances of preventing nerve damage and preventing buildup of nerve damage in the future also. Now, some so-called rarer neuropathies, but perhaps not that rarer after all. So let us first go to the autoimmune nodopathies or the nodoparanodopathies, and just one slide on this. So these nodopathies can Some of them can mimic GB, some of them can mimic CIDP. And what we need to know is that they are distal predominant, they can have sensory ataxia, they have poor response to IVIG because they usually IgG4 mediated. They are usually demyelinating, and they are predominantly the IgG4 subclass, which is why, in fact, they do not respond that well to IV immunoglobulin and do well with rituximab. And out of this, I would just like to mention four important ones. That is, one is NF155, which is associated with tremor, cerebellar dysfunction, autonomic dysfunction. Rarely they can have central and peripheral demyelination. Then we have the Casper1, or the contacting antibody, and they can have neuropathic pain. This can also have GBS-like presentation. And then we have a CISP like, which is contacting antibody associated autoimmune neuropathy, and this can have a CISP like presentation, chronic immune mediated sensory polyneuropathy. And it can also have nephrotic syndrome, so there can be a systemic involvement as well. This is IgG3, while the rest all were IgG4. Then we have the pan NF antibody associated one, which has a fulminant course. And recently we have been seeing these GBs which progress within hours and then go on to be ventilator dependent, and then even they have a very slow recovery. So here probably these are underlying neuropathies that may have been going on undiagnosed so far. So this is still something, the lot of research is going on in this, and a lot of new papers have come. So any a lot of we can read up about it also. And then coming to vasculitic neuropathy. Now, what we need to understand about vasculitic neuropathy is that we can have neuropathy due to systemic vasculitis. So, neuropathy in the context of RA, neuropathy in the context of established Sjogren's, or we can non-systemic vasculitic neuropathy. And this is one of the indications where, in fact, we have to consider a nerve biopsy, because there it becomes necessary to make a clinical diagnosis. So, under vasculitic neuropathy, it can be a small vessel, medium vessel, large vessel. And under the secondary systemic vasculitis, we have RA, SLE, Sjogren's, systemic sclerosis, dermatomyositis, sarcoid, Behçet's, etc. Now, this is, of course, based on the beautiful diagram, especially from the rheumatological point of view, dividing, into the large, medium, and small vessel vasculitis. So when we talk about the patterns of involvement in vasculitic neuropathy, we have three primary patterns. And this is the multiple mononeuropathy, which is also the mononeuritis multiplex. And this is sequential involvement of non-contiguous nerves. And then we have the distal sensorimotor polyneuropathy, which is again the length-dependent pattern. And then we have the plexopathy as well. And what happens is this multifocal, multiple mononeuropathy or mononeuropathy multiplex is asymmetric and multifocal at presentation. But the same disease, when it evolves and progresses, and if there's no intervention done in between and no medication given in between, can progress into a symmetric pattern simply because of extensive involvement of all peripheral nerves. And this is a very classic non-blanching palpable purpuric skin lesion. And so this is something which I will revise again in the head to toe examination when you have a patient with peripheral neuropathy. And so the typical features of vasculitic neuropathy as per the Peripheral Nerve Society are sensory or sensory motor involvement, asymmetry, multifocality, lower limb predominance, distal predominance, pain, acute relapsing course, and electrodiagnostic evidence of an axonal sensory motor sensory neuropathy. So all these features go in favor of a vasculitic neuropathy. Simple to say that if you have an underlying primary or secondary vasculitic process, for example, a patient with proven RA who comes to you with this clinical phenotype, you can make a diagnosis of vasculitic neuropathy without doing a nerve biopsy. But if all these factors are not there, so basically this is again sensory motor, distal predominant, and you're having an axonal pattern on the conductions, then again likely vasculitic neuropathy, and you can treat as such. And then when you have a non-systemic vasculitic neuropathy, here is where things become a little dicey. So here you do need a nerve biopsy, and you need a nerve biopsy showing intramural inflammation accompanied by pathological evidence of vascular damage. You need the clinical features of vascular neuropathy, no atypical features like purely motor symptoms or entirely proximal signs, lack of asymmetry, etc. And no evidence of another primary disease process that is known to be associated with vasculitic neuropathy, like a lymphoma or a lymphocyte or amyloidosis, etc. So this is a summary, can go back and go through this, of all the types of immune-mediated neuropathies and their key features. Then moving on to neuropathies associated with monoclonal antibodies. And this, what we need to realize is that approximately 10% of patients with peripheral neuropathy diagnosed by electroclinical studies do have a monoclonal gammopathy. Now, it may be a monoclonal gammopathy of unknown significance, or it may be associated with bone marrow plasmacytosis, but there is an underlying monoclonal gammopathy. So remembering to send a serum protein electrophoresis as part of your workup of peripheral neuropathy patients should be something that we should all incorporate in our practice. So it is more common with the IgM variant rather than the IgA or IgG monoclonal antibodies. And for this, we send first step serum protein electrophoresis. And then if it comes negative and we are still sure, we can send an immunofixation, which is more sensitive. And light chain assay is also something else that we can do. And monoclonal gammopathies occur in 3.2% individuals over than 50 and 5% of those older than 70 years. And because one thing is that it is said that it could be coincidental, because as age increases, also this gammopathies incident increases, but it is still something that we shouldn't forget. Now, basically, when we have neuropathy and we have an underlying paraprotein, we rule out other causes and we see, is it an IgM paraprotein or is it a non-IgM paraprotein? If it's an IgM MGOS neuropathy, then is it anti-MAG and it is mainly demyelinating. If it is non-IgM paraproteinemia, are we dealing with POEM syndrome or are we dealing with amyloid light chain amyloidosis? POEM syndrome, as we know, is a systemic syndrome. There is polyneuropathy, demyelination axonal loss, elevated VEGF, which is an important biomarker that we should remember. They also have papilledema on fundus examination. And corticosteroids, I'm sorry, this is of the nodopathy one, so let's just ignore this slide. So essentially, in a patient where a monoclonal gammopathy is detected, it is the management of the underlying gammopathy that may lead to or stabilize or improve the neuropathy, and that is something we should remember. And this is a diagrammatic representation of POEMs, and this is one of the cases where we have hyperpigmentation and hypertrichosis, and that is one clinical clue that we shouldn't miss. And on skeletal survey, we can have isolated bone plasmacytosis and plasmacytoma, and they do respond very well to radiation. So what we need to keep in the back of our mind probably is that when we have a demyelinating pattern of peripheral neuropathy in an elderly person, do make sure that you send a protein electrophoresis as part of your basic workup. And then coming to a little rarer a cause, that is a copper deficiency, but something that we shouldn't forget. And these patients also present with sensory ataxia. This copper deficiency is associated with small intestinal malabsorption or zinc ingestion. So many people actually take zinc as a supplement, and they can have a tendency to develop copper deficiency. And this is something we need to remember, especially when we're taking history of these peripheral neuropathy patients, because they may not volunteer to tell you that they're taking zinc, or for that matter taking vitamin B6. That toxicity itself can also cause peripheral neuropathy, which is why it's very, very important to take a detailed drug history, including history of all supplements in your patients who are presenting to you with peripheral neuropathy. And vitamin B6 toxicity again is associated with sensory neuronopathy. It can affect the dorsal root ganglia, and things that dorsal root ganglia, that sensory ganglionopathies. So they have a tendency to present with severe ataxia, and they have a very few differential diagnoses. And B6 toxicity is one thing that should also be considered here. So I have not spoken in detail about toxins and drugs because there is no scope of doing that here, but they are all in general axonal in nature. And I will have a small discussion on demyelinating variant, which is a little less common. So now let us come to how do we clinically evaluate. I'm not talking about labs here. What do we do in our clinical examination? Vital signs, never forget to check one orthostatic loss of orthostatic drop of blood pressure, a very simple bedside test that could give you a clue that there is some autonomic dysfunction present as well. Skin examination, look for skeletal deformities. Skeletal deformities is something very important to look for, because this could indicate that patient is having an underlying inherited neuropathy. And it's always important to examine family members as well. When the moment you see one skeletal deformity, examine the families as well. When you're doing a motor examination, as we discussed, that most of our neuropathies are sensory predominant. So to pick up this subtle motor weakness might be difficult. A simple test is to make them walk on their heels, walk on their toes in your OPD, and detect this very subtle motor weakness. And sensory exam is something which is very sensitive. You having a tuning fork, we know our 128 hertz tuning fork starting from the distal most areas and coming going proximally, something very can pick up the earliest of peripheral neuropathies. And then of course reflexes. So this was a very brief clinical examination what we will do. And what we need to remember is that while positive sensory symptoms are quite commonly seen in acquired neuropathies, absence of positive sensory symptoms are commonly encountered in genetic neuropathies as well. Now, on physical examination, what are the things that would strike out to you? Are there any non-blanchable purpura? Could it be a vasculitic neuropathy? Hypopigmented patches. Never ever forget to check this, because again, leprosy can cause mononeuropathy, multiple mononeuropathies as well. So looking for a hypopigmented patch is very important. Presence of angiokeratomas is something we see in Fabry's disease. Orange tonsils is something very classically seen in Tanger's disease, but something that I have never encountered, but something that we need to remember. Skin hyperpigmentation can be B12 deficiency, can be Poem syndrome, very important. Clubbing to be seen, whether especially when you're suspecting a paraneoplastic manifestation. Meese lines, which can be seen in arsenic or thallium intoxication, and retinitis pigmentosa nictiosis, which can be seen in Refsum's disease, which is also a relapsing form of metabolic inherited peripheral neuropathy. And then there can be trophic changes, especially seen in patients with small fiber neuropathy associated with pain, allodynia, etc. And these patients, it's difficult to pick up because their nerve conductions also can be normal. And because I will not be talking about small fiber in detail, I'll just tell a word about it here. So small fiber neuropathies, the patients present with severe positive burning sensory symptoms. They can have burning paresthesias. Clinically, it's very difficult to pick it up. Nerve conductions are normal. Even if the patients are non-diabetic, it is worthwhile doing a glucose tolerance test in them, because impaired glucose tolerance is also associated with these small fiber neuropathies. And to prove them, what we do is we do a skin biopsy and look for intraepidermal nerve fiber thickening, the nerve fiber layer, and that is what gives us a clue towards small fiber neuropathy. And then again, systemic features, what we will examine is diabetic retinopathy, angiokeratoma, organomegaly, orange tonsils, again reiterating what I've already told before. And again, this is a summary of head to toe what we need to look for. But this slide is probably very important for any resident, and something that you need to keep in the back of your mind when you are examining patients. For example, patients with hearing loss and peripheral neuropathy, think of mitochondrial disorders. Look for presence of alopecia, hyperhidrosis, which can hypertrichosis, which can be seen in malignancy as part of your Poem syndrome. And if there's renal involvement, there can be diabetes. So this is an important slide that we should need to remember. Now, during a general physical examination, not examining for thicker nerves is basically not acceptable, because there are, again, this gives us a very important diagnostic clue. So thicker nerves are basically seen in leprosy. Localized thicker nerve can be seen in neurofibromatosis, Refsum's disease, amyloidosis, HMSN, diabetes, sarcoid, and very important, I'm sorry it's not mentioned here, that's CIDP, where you see thicker nerves. So this is again reiteration to the point that skeletal deformities do think of the possibility of underlying inherited neuropathies. Now, so on your general physical examination, in addition, you will do your you will look for any kind of subtle motor weakness. You will examine for reflexes. You will examine for all your sensations, and you will look for head to toe signs of any markers of an underlying systemic disease. On your history, you will take whatever history or you can take in terms of tempo of progression and exposure to drugs, toxins, and very importantly, constitutional symptoms, whether there's been any weight loss, whether there's been any loss of appetite, things that could suggest that there is a systemic disease at play. And now, when do we need to start evaluating a patient with peripheral neuropathy? So what features should tell us that yes, we have to do it? Because peripheral neuropathy, if it's 1% of the population, we can imagine the number of patients heading to our OPD with them. So the moment patient has asymmetry, it is non-length predominant, motor predominant, acute onset, predominantly autonomic, rapidly progressive, sensory ataxia. These are situations where you need to go ahead for a complete evaluation, complete red flag signs. And especially if you have painful progressive asymmetric mononeuropathy, think, could it be vasculitis? If it is rapid progression, is it GB or one of GB or its variants? If it is severe neuropathic pain with weight loss, amyloid, vasculitis, paraneoplastic. If it is severe autonomic failure, autonomic neuropathy, and again here we need to remember amyloid as well. Diabetes being a very close common cause. Porphyria is another cause. So what are the, if you want to summate the investigations, we do a complete hematological panel, metabolic panel, and then we do the neurophysiological testing, which includes a nerve conduction study and an EMG as well. And finally, if we don't have an answer, in select cases, we decide to do a nerve biopsy. Now, I will not go into this, but this is a breakdown of everything, and it begins from blood count, and it will go up right up to a PET scan. So choosing what you need to do again will depend on the type of neuropathy you have determined the patient to have. So is your patient having a predominantly axonal neuropathy or a predominantly demyelinating neuropathy? Now, the thing is that most of the neuropathies that I discussed with you today, be it toxin, diabetes, drug exposure, most of them cause an axonal form of neuropathy. Even the idiopathic variants are all axonal. So for us, the workup will change based on whether it is axonal or based on whether it is demyelinating. So for this, a very invaluable tool is the nerve conduction studies. So in the nerve conduction studies, the parameters that we know are, there is distal latency, conduction velocity, which represents the saltatory conduction, the speed of transmission basically across the nerve, and then we have the compound motor action potential, the motor unit, the amplitude, which represents the number of axons. So to put it very simply, this diagram illustrates this. In axonal neuropathy, we have a reduction in the amplitudes, while in a demyelinating variant, what we have is a prolonged distal latency with reduced conduction velocity, because myelination is lost, saltatory conduction is lost, and velocity is lost there. And in the demyelinating variant also, we have demyelination with conduction block and demyelination without conduction block. To put it very simply, and for lack of time, conduction block is a phenomena seen when there is difference in the transmission, the conduction velocity across each fiber, which will happen in an acquired demyelination, because each fiber is affected differently, as opposed to an inherited cause of demyelination, where we will have uniform demyelination without conduction block. So conduction block represents that if as for example, if a person is running at 30 kilometers per hour, driving at 30 kilometers per hour, and another person at 20 kilometers per hour, at the end of 1 hour, how far they will be? The conduction block represents that, the lag between the distance traveled, the conduction velocity of the nerve fibers. So that is, to put very simply, how we interpret a nerve conduction study. So once we have done a nerve conduction study, and we say that the mechanism is likely axonal, we proceed to the axonal workup. Now, one small point here. Now this is electrophysiologically, to reiterate how we can clinically differentiate between an axonal variant and demyelinating variant, which may not always hold good, is that an axonal variant is likely to be length dependent. An axonal variant is likely to represent more of motor weakness associated with wasting, while demyelination may not be length dependent, may be proximal. Demyelinating variant will be associated with areflexia, rapid onset, rapid offset, and good recovery as well. So coming back to the axonal workup. So here we do a CBC, we do a metabolic panel, we do serum glucose, glyco HPB12, SPEP, and then these are the high yield works up, and the lower yield are the thyroid functions, ESR, CRP, ANA, and folic acid. And then now you, if your tier 1 still did not give you an answer and you want to move ahead, then you do your nutritional panel, you look up, you do your serology, you still feel that could be a gammopathy, you do a urine protein electrophoresis, immunofixation, check for cryoglobulins, ANCA, ANA, and then the final tier will include genetic testing, CMT2, because remember CMT1 is a demyelinating variant, or you can do a salivary gland or abdominal fat pad biopsy. This is for amyloid, malignancy workup, anti-neural antibodies if you're suspecting an underlying paraneoplastic syndrome, and genetic testing for trans hereditary, and this is where you're suspecting familial amyloid polyneuropathy. But again, to go up the tier, you need to take a call whether you feel that the patient is having a progressive disease. If a patient has come to you and since 2-3 years he has been stable, non-progressive, perhaps it's not worthwhile to subject him, let's say, to a genetic test. Again, there it will be important to eliminate more commoner etiologies. And now coming to demyelinating neuropathy, and the reason I'm devoting the next few slides on demyelinating neuropathy is that demyelinating neuropathies represent a lesser common type of neuropathy. These are more likely to have a treatable etiology, and since most of them are inflammatory, immune mediated, we should not miss these kind of neuropathies where there is a treatment. So that's why I'll be focusing on it. So this we have already discussed that axonal neuropathy affect the longest nerves. So there is length dependent pattern, but to whatever I have told you, there are exceptions that even in demyelinating neuropathy, symptoms may still begin in the distal extremities because the longest nerve have the most myelin. Okay, but even here, hands and feet may be affected simultaneously, even though it is distal predominant, unlike the length dependent, where the progression had to be up to mid thigh for the hand sensations to be involved. And so these myelinopathies or demyelinating neuropathies are uncommon. The clinical clues are thickening, nerve thickening, global areflexia, weakness without wasting, motor greater than sensory defects, and of course NCVs. And again, demyelinating polyneuropathies, we know they can be acquired or they can be inherited. So it's important to differentiate between the two. So we know acquired can be subacute or acute in onset, while inherited are chronic. Progression is rapid, while it is slowly progressive here. Family history can be absent, may be present in especially autonomic dominant neuropathies. Distribution can be asymmetric, especially at onset, while it is symmetric inheritance. And electrophysiology, I already elaborated that conduction block temporal dispersion is something seen in acquired and not in the inherited version. Other clinical clues, and this very important, is this muscle weakness that is disproportionate to the wasting. In an axonal neuropathy, the wasting and the weakness kind of go hand in hand as compared to these demyelinating neuropathies. So these are some clinical clues we should keep in our mind, because we may not have nerve conduction handy always. And of course, we have very specific and stringent criteria to say that it is demyelinating neuropathy. And I will not talk about the inherited or the hereditary neuropathies, but among the acquired demyelinating, what we need to remember, we of course have spoken about CIDP, we know about AIDP. Multifocal motor neuropathy is something that can often mimic, it is pure motor, it can mimic an anterior horn cell pathology, and it is something that we should never ever miss. Diphtheria can also produce an demyelinating form of pathology, and toxins, even though toxins usually cause dying back and axonal variant, few toxins like amiodarone, arsenic, etc. can cause a demyelinating form as well. And if it's immune mediated, if it's a GB, CIDP, multifocal motor neuropathy, even in paraneoplastic infectious cases also, and toxin mediated, which I've already elaborated, we can get demyelinating varieties. And I will not go into detail into inherited demyelinating neuropathies, but some clinical clues is that if it's early onset, slow progression, along with foot deformities, no inflammatory markers, no conduction block, and uniform slowing on your conductions, do think of inherited demyelinating neuropathies. Now coming to biopsy. So we said we will analyze based on history, examination, the blood workup, the electrophysiology. Based on the electrophysiology, a guided workup. Now, when do we think of doing a biopsy? So if you have a patient where you're suspecting a non-systemic vasculitic neuropathy, definitely yes, you have to go ahead for a biopsy. Patient with florid autonomic symptoms, you're suspecting amyloidosis, yes, there we do need a biopsy. Leprosy, which is an infiltrative pathology, yes, you do need a biopsy there as well. So when you have clinically run out of possibilities of evaluation, and your patient has progressive symptoms. Now, in the same scenario, if a patient has come to you who has been having some sensory symptoms progress that have hardly progressed, which have remained stable for around 2 to 3 years, doing a biopsy may not give us much of a yield. The biopsy will just say non-uniform sensory axonal loss, and then we will be in a dilemma as to what to do next. We would have subjected the patient to a invasive, potentially, because some of them do have a lot of pain on follow-up. So we have to be very careful about asking for a biopsy, and we have to have a set of differentials in our mind of what we are considering before we consider the possibility of a nerve biopsy. Now, this was about the evaluation part. Very briefly, certain clinical clues that we should keep in our mind. The moment we have acute onset or abrupt onset, we do think of GB, yes, always, but we do need to remember that vasculitic neuropathy also can have a very acute presentation. It can mimic GB as well, as can porphyria. Among infections, more in India, it is Lyme's disease and arsenic. These are all GB mimickers, and these are all things that we should keep in the back of our mind. Subacute, this we know, CIDP, DM. Basically, these are inflammatory, toxin, and nutritional deficiency. Relapsing remitting course, again, this is rare compared to the relentlessly progressive course, and this should give you a clue that it could be CIDP, porphyria, hereditary neuropathy with tendency to develop pressure palsies, or even Refsum's disease. But these three should be something that we should never forget. And if it is a stepwise progression, we should also consider the possibility of a vasculitis. And if it's painful neuropathy, diabetes, alcohol, paraproteinemias, vasculitis, amyloidosis, very, very important, and paraneoplastic sensory neuropathy and idiopathy. If it is motor predominant, again, porphyria, lead, or a motor predominant CIDP. If it's autonomic involvement, diabetes, GP, amyloidosis, porphyria, HIV. These are things we should never forget. And if there is associated cranial nerve involvement, it could be diabetes, GB, Lyme's, sarcoid, diphtheria, or Friedreich's ataxia technically will not come here. And demyelinating neuropathy, we already spoke about amiodarone, something we should never forget because it's something we commonly use. And for a final summation of the evaluation of peripheral neuropathy, I'll just break down this slide into 3 parts. So on history, we take the symptoms. Is there sensory, motor, autonomic symptoms, gait instability? Then we try to locate the symptoms, length dependent, long length dependent. We look for symmetry, we look for the time course, and we look at what are the risk factors that could have predisposed the patient to the peripheral neuropathy. On physical examination, we look for sensory loss. Again, very, very important to be done aptly. We look for deformities. We look for impaired proprioception, very important, along with vibration, checking for vibration. And we check for motor impairment. Then, for the typical length-dependent peripheral neuropathy, what we see is sensory involvement, symmetrical signs, more severe in the extremities, symptom onset and progression over months to years. And for these patients, we think of doing a first rule out a glycemic, this B12 deficiency, protein electrophoresis, HbA1c, and we know the common etiologies here. When it is atypical, that is non-length dependent asymmetry, then we have to go for the higher level investigations. Maybe we need autonomic testing, lumbar puncture, nerve imaging. We follow the other algorithm. And nerve conduction study, of course, it will tell us whether there is an axonal pathology or a demyelinating pathology. So this is the stepwise progression that we should follow. Now, coming to the management of peripheral neuropathy, once a etiological diagnosis is made, the management becomes very relatively easy. The problem with peripheral neuropathy is making that etiological diagnosis. But in general, for sensory symptoms, this I've already told that for patients with lack of sensation, because especially diabetic patients who already have concurrent microvascular disease, they should be told to simple things like check the temperature with the hand before putting their feet in really hot water, and taking precautions of wearing footwear in and around the house, even outside, of course. And then in case of high risk of foot ulcers, they can always have a podiatric consultation. And for the neuropathic pain, this I've already told, especially in diabetic patients. For some patients, actually, it's very mild, and they can try with, just soaking the water in feet in cold water, some moisturizing cream. Topical treatments such as capsaicin, lidocaine are approved. And if this doesn't work, these are of course for the mild ones, then we have a step ladder where we start off with duloxetine. If it doesn't work, we go to the gabapentinoids, which can be gabapentin or pregabalin. Again, we have to be a little careful there, because a lot of data is coming up in saying that pregabalin is not that safe in patients with cardiac comorbidities, gabapentin not that safe, long term use is associated with a higher incidence of dementia. So we have to be a little careful with these drugs as well. And for patients with motor weakness, and of course, because of the added proprioceptive loss, there is more risk for falls. So for them, physical therapy and occupational therapy, gait and balance training does make a lot of difference. And what we have to do is that always try associate disease modifying agents, alcohol cessation. If it is a particular chemotherapeutic drug, perhaps switching over in consultation, the oncologist might in consultation neurologist switch over to something less neurotoxic, initiation of immunotherapy if it's an immune mediated pathology. And always remember that, let's say you start duloxetine 20 mg today, tomorrow patient comes back, which like they commonly do, and say my pain is not subsiding, what kind of a horrible medication you've given. These medications take time to act. At least the initial response may itself take up to 2 weeks. And before saying that the patient is not responding sufficiently, the dose also has to be adjusted. So that is something that we should understand. And for patients with autonomic dysfunction, we always, of course, prefer non-pharmacological maneuvers, which include drinking fluids, using compression stockings, asking them to have less carbohydrate diet, and avoiding rapidly getting up and sitting down. And in refractory cases, we can try with fludrocortisone or midodrine, depending on the comorbidities. And general care we've already spoken about. And what we need to tell the patients is that once we have a diagnosis, we have a closure for the patient. They know what is going on, but diagnosis doesn't always mean that there is a treatment. So especially when we are suggesting invasive diagnostic modalities, but what we need to make sure about is that we are not missing out a ongoing systemic process that is causing progressive neuronal damage, and which, if detected early, the treatment can make a huge change, like a paraneoplastic manifestation. And what we need to remember is something that I spoke about at the beginning of the class, beginning of this talk, that despite all the workup, and this was a very recent study, which said that 12 to 49% patients of polyneuropathy can have no identified cause. These are, of course, the length-dependent polyneuropathies, because the moment you have an asymmetric pattern and you have a mononeuropathy and entaplant neuropathy, we are more likely to make a diagnosis there. So here I come to the final part of this talk today, which is the importance of formulating a pattern recognition. So I will circle back to this. So what we need to do, we need to localize the lesion. With the help of electrodiagnosis, we can quantitate the severity, assess possibly what is the course. Now, I spoke about nerve conduction study, but I did not speak about EMGs. So electromyography are also very important tools that we do use in assessment of peripheral neuropathy. There are markers to suggest that there is active denervation, saying that there's ongoing damage. Markers to tell us that there is re-innervation, to say that, okay, fine, there is some attempt at healing happening. It does help us prognosticate also. So for a patient with peripheral neuropathy, and EMG is also pretty important. So there is this 3-6-9 approach that makes things a little easier when followed in peripheral neuropathy. So the three core goals are: what is the lesion? Is it a neuronopathy? Is it a peripheral neuropathy? What is the cause? Is it hereditary? Is it acquired? If acquired, metabolic, immune mediated, what? And can therapy alter outcome? So if you have a patient with idiopathic neuropathy, you may have even done a biopsy and there is no evidence of inflammation, it does not make any logical sense to add the patient on immunomodulation, add the patient on steroids. So is our therapy going to cause any help or do more harm than good? Once we have fulfilled these goals, we have to answer 6 Key clinical questions. What are the systems involved? Is it proximal? Is it distal? Is the distribution symmetrical or is it asymmetrical? What is the sensory profile? Is there pain, burning, loss of proprioception? Are there UMN signs as well? So do we have to consider something like B12 deficiency, where you can have both UMN and LMN features? What is the time course? Is it acute, subacute, or chronic? And is there any clues to suggest that there is an underlying hereditary neuropathy? What we need to remember is that the pace of progression, the tempo of progression should be considered separately from the onset. And most peripheral neuropathies will follow a gradual, slowly progressive course. Toxic, metabolic, genetic, they have barely noticeable or detectable decline. What we need to do is differentiate between a monophasic illness versus a chronic progressive disorder, like a autoimmune neuropathy. That is very important. And when we have rapid accumulation of peripheral nerve disorders, we have to consider the possibility of an underlying autoimmune neuropathy. And when we have a stepwise accumulation of deficit, we have to consider the possibility of a vasculitic etiology. So finally, coming to the pattern of neuropathic disorders, and I would still talk about 369 among this pattern. 8 is something that doesn't fall under the spectrum of peripheral neuropathy. So if these patterns will help us try to lessen the amount of narrow down our differential diagnosis. Pattern 1. Most common symmetrical, proximal, and distal weakness with sensory loss. So here it can be inflammatory demyelinating polyneuropathy. Pattern 2 is symmetrical distal sensory loss with or without distal weakness. My apologies, this is the most common one. So here it is either cryptogenic, metabolic that we discussed, drug toxins, CMT type 1. Then we have pattern 3, which is asymmetrical distal weakness with sensory loss. And here the most common thing that we have to consider and rule out is, of course, always vasculitis. HNPP, MADSAM variant of Lewis-Sumner variant of CIDP should also be considered here. That is asymmetrical distal weakness with sensory loss. Pattern 4 is asymmetrical proximal and distal loss. So this is most commonly a radiculopathy or a plexopathy, which can be due to diabetes, or it can be infiltrative like meningeal carcinomatosis, sarcoid, amyloid, etc. Then pattern 5 is asymmetrical distal weakness without sensory loss. So here, if a patient has upper motor neuron signs, you have to consider the possibility of ALS. Without upper motor neuron signs, it could be PMA, it could be amyotropic diplegia. Here, multifocal motor neuropathy also comes into play. Juvenile monomelic amyotrophy is also present. And this is a rarer variant, that is asymmetric distal weakness without sensory loss. Symmetrical sensory loss and distal areflexia. So here again, B12 deficiency is something we should consider. Copper deficiency, which mimics B12 deficiency also. Then we have symmetrical weakness without sensory loss. So here it can be SMA, or if it is distal weakness, it can be hereditary motor neuropathy. Then we have the focal midline proximal symmetrical weakness. Here, if it is neck extensor weakness, consider ALS, bulbar weakness, myasthenia, etc. That doesn't exactly fall under the spectrum of peripheral neuropathies, but it is a pattern of weakness. Pattern 9 is asymmetrical proprioceptive sensory loss without weakness. And this here is ganglionopathies or chronic immune sensory polyradiculopathies that we should consider. And then finally, pattern 10 is autonomic symptoms and signs. So here we have to consider neuropathies with autonomic dysfunction, which I have said is what we need to always remember is amyloidosis, diabetes mellitus, HIV, porphyria, things that we haven't to miss. And this is kind of a beautiful graph that kind of summates our basic differentiation. So here we have in blue pattern 1, and this is hereditary, and we can see that the disability over years is very, very slowly progressive, barely perceptible. Then we come to, if it is metabolic or toxic, again, the tempo of progression is definitely faster, but the most rapid progression is immune-mediated, vasculitic, paraneoplastic, where we can see there's hyperbolic curve and there is rapid progression of symptoms. So, if we put everything together, and we talk about the patterns, we talk about the clinical element, we talk about the electrophysiological element, this is taken from Continuum, and I think this beautifully summarizes the whole thing. So, if we take it on onset and pace, So here it is very simple. Is it chronic or is it acute? So if it is chronic onset, gradually progressive, here are the most common toxic, metabolic, chemotherapy related, hereditary. If it is acute or subacute with rapid progression, days to months, here you have all the spectrum of your inflammatory neuropathies, which include GB, CIDP, paraneoplastic neuropathy, infective neuropathies like Lyme's, leprosy, everything will come here. This is based on onset and pace of progression. If we are talking about the anatomical distribution, here we have length dependent, again, the garden variety complaints, we have garden variety causes, we have the multifocal ones, wherein here comes the leprosy and the vasculitis and even diabetes. Bulbar involvement, we have to consider GB. Monomelic element, monomelic variant, it is focal compression. And then if it is sensory motor involvement, depending on the pattern of fibers here. If it is predominantly sensory with minimal and late motor, again, this is the most common one that we encounter, toxic metabolic. If it is prominent proprioception, this is sensory neuronopathy or a dorsal column spinal disease. If it is pure motor, it is multifocal motor neuropathy. If it is predominantly early motor involvement with sensory involvement, it can be GB, CIDP, paraproteinemic neuropathies. And based on the electrodiagnostic findings, again, the distal multifocal segmental demyelination or diffuse demyelination, this we have already discussed. So what are the take-home points? Pathology guides treatment and prognosis in immune-mediated neuropathies. Temporal evolution of symptoms and the timeline is of paramount importance in appropriately diagnosing and treating. When not responding to regular treatment, always consider alternative diagnosis and follow guidelines and management protocols whenever in doubt. So I have included it as an appendix in the later slides. Anyone interested can go through. For example, even if you are suspecting an inherited neuropathy, there are algorithms that will tell you which type of genetic test to ask for. If you're suspecting CIDP, you have stringent electrophysiological criteria that tell you, are you making the right diagnosis or no? If it is vasculitic neuropathy, also you have strict diagnostic criteria. If you apply these diagnostic criteria, and if your patient doesn't fall into them, then it is something somewhere has been missed out. And always when you're thinking of what else can it be, if your patient has stable symptoms, it could be residual symptoms from a past insult, okay? Or if it is progressive, then it could be a lesser common cause, like a non-systemic vasculitis or an atypical CIDP not missing your criteria, or a gammopathy. So that is something that we need to remember. So I won't go to the appendix, but for anyone interested, I have put a summary of basically everything and a guide for inherited neuropathies and something on patient education of what you can tell. So with that, I'd like to conclude my talk today, and I hope it was not too boring, because there's a lot of theory involved behind peripheral neuropathy, and it is very frustrating when we have patients walk into the OPD and we are not able to give them a clinical diagnosis, and then they say that, okay, we have done so many tests and you're not able to tell us, and then we say, okay, fine, we will do more and do more. We need to see the clinical profile of the patient, identify red flag signs, see if there's a systemic disease at play. And very important is this history taking in terms of drugs and toxins, because I've often encountered, because they don't even consider these supplements as drugs, and things like B6, zinc causing copper deficiency, Ayurvedic medications, illicit Ayurvedic medications, containing heavy metals. All these things have to be kept in mind. And if a patient, just because a patient is diabetic, do not label it as diabetic peripheral neuropathy. Again, if there's predominant motor weakness, asymmetry, rapid progression, do consider the possibility of a concurrent inflammatory pathology as well. And if you see if you have a patient coming into with peripheral neuropathy who has a lot of constitutional signs of weight loss and loss of satiety, etc., do consider the possibility that this could be a paraneoplastic manifestation. And in these cases, you chase all possible investigations, including and not limited to a PET scan. But and finally, never forget to include protein electrophoresis as part of your diagnostic work. So thank you very much. And with this, I think I will conclude. If there are any questions, you can.
Thank you so much, ma'am, for your presentation. We have a few questions that have come in during the session. I'll just take them up one by one. Yes. Dr. Sunita Thomas has asked, can multiple sclerosis cause neuropathy, and what is the treatment for the same? How to prevent a neuropathy?
So multiple sclerosis by definition is a central demyelination which affects the white matter of the brain and spinal cord. By in itself, multiple sclerosis does not cause peripheral neuropathy. There are very rare cases where recently, I believe, in St. John's, they have a case series of this where they have found both central and peripheral demyelination, but those are different antibody mediated inflammatory neuropathies. So to come circle back to this question, multiple sclerosis by in itself has no direct causation or association with peripheral neuropathy.
Yes, ma'am. Another question here by Dr. Chandra is any correlation between duration severity of diabetes with neuropathy and any
Yes, there is.
correlation with obesity?
And obesity, yeah. So that's a nice question. So it is said that most diabetics will go on to develop peripheral neuropathy, but the onset will, especially I'm talking about type 2 diabetic patients, because in type 1 diabetic patients it basically depends on glycemic control. In type 2 diabetic patients, the longer the duration, the more the risk the patient is at to develop peripheral neuropathy. The more poor the glycemic control, definitely earlier the likelihood of having peripheral neuropathy. And obesity, dyslipidemia, the metabolic syndrome, uh, and in terms of lifestyle, including things like smoking, are detrimental to the tempo of progression for peripheral neuropathy. So in the type 2 diabetic patients, peripheral neuropathy management will not just entail glycemic control, it will also entail control, dyslipidemic control, and lifestyle control, weight loss, etc. So that is something that we should all advise our diabetic patients.
Yes, ma'am. Dr. Jayashree Sampath has asked, can patient have pedal edema in long-standing diabetic neuropathy, and what should be
So
the treatment?
the thing is that there are multiple systems at play here, because diabetic patients with neuropathy may also have concurrent proteinuria secondary to nephropathy, so that may itself predispose them to pedal edema. There are also a lot of vasomotor changes that happen in patients with diabetic neuropathy because of autonomic nervous system involvement, so that can also predispose patients to develop pedal edema. So it would be a multifactorial thing in play over there.
Yes, ma'am. I think those are all the questions that have come in. If there are any more questions, you can write them in the comments now or later, and I can always ask ma'am and answer them for you. Thank you so much, ma'am. Thank you.
Yeah,
Yes.
thank you.